What a great speech to come after Graham. A bit difficult. It was a great topic that he talked about, and one of the things that really jumped out from me was, if you want to go far, go together. And that probably is a pretty good theme for what I want to try and talk about this morning. So I was originally invited to talk about regulatory reform, and I will touch a little bit on that, but I was always kind of planning to talk about how we might collaborate better together. I think that's the right conversation that we need to be having now. So now, what I would actually say is the reason why we need to have this conversation is because we share the same customers. We live and die by the same sword. We could be going through what Garrett Hardin described as the tragedy of the commons. If we're not careful, as individuals working in our own self-interest, we'll deplete a very important common resource that will hurt us all. And that common resource, of course, is the increasingly shrinking share of wallet of the consumer. So, as long as providers have an incentive to maximise their revenue and undertake activities regardless of whether they're cost effective or clinically effective, then the risk is we're both going to lose out. So a perfect example of this, because I do like to give evidence and not just throw things out there, is rehab in Australia following joint replacement. So I guess an example for us of that is that in most other countries, what's offered to people following joint replacement is in community or in-home rehab. But in Australia, Bupa members are being transferred at quite high rates, 50%, sometimes up to 80% in some facilities, to inpatient rehab. Now, this is made even more costly for us, where hospitals are building their own inpatient rehab facilities, and they're also then not agreeing to bundle the rehab costs into the payments. And what we've found is this is just driving up costs. So where we have had hospitals who have agreed to bundle in rehab, we've seen inpatient rehab costs halved. And basically, at the end of the day, customers are giving us money, and it's our job to make sure that we spend it as well and as prudently as we can for them. So, affordability is an issue. Now, we all want a viable and affordable product. Any kind of product needs to remain attractive and affordable. But in Australia, we have the principle of community rating. So it's even more important for us, because if we can't retain and hold on to those young and healthy people, and as many of them as possible, what we'll see is a price spiral. And we have seen this happen in the past. So what we will see are older and sicker people holding on to their products because they need them, with an increasingly shrinking risk pool with which to share the risk. And eventually, even the old and sick won't be able to afford the product. And I'm sure this kind of spiral is not something any of us want in this room. So it's not so much whether health insurance or the health sector can survive, but really what a distressed consumer will do and how they will impact on the whole of the private healthcare sector. So, while regulatory reform can help us to manage some costs, the reality is if we don't start collaborating together, then we really are going to be facing some really difficult challenges ahead. Yet to date, we haven't seen a lot of focus from hospitals working with doctors on value for money. So we also question whether there might not be a need for private hospitals to start having this focus if they want to survive. As pressure on cost, pressure for value for money increases, you're going to risk seeing some competitors come in with low-cost structures who will be disruptors in the private hospital sector as well. So one example that I thought I could share with you that we would like to see looked at is the requirement, often without any, visibly to us, a reason that people should not be discharged until their doctor has done their round and cleared them for the day. And often that can happen quite late in the day, and then before you know it, they're staying another day in hospital. So just questioning, is that always necessary in every circumstance, or is it just driving up costs? I was asked to talk about regulatory reform, so I will just touch on that, but I'm probably then going to talk a little bit more about collaboration. So in terms of regulatory reform, we want to look at regulatory reform that will ensure allocative efficiency, unleashing savings in the system, and that's basically the theme of both what we want from regulatory reform, but also what we want from collaboration. One of the areas that we think this is possible is prostheses reform. So we know that there are a lot of savings to be found based on international benchmark pricing. We also know there's potential for insurers to share the savings with a lot of the purchasing arrangements between hospitals and suppliers. So this is the area that we would like to see some focus on in terms of regulatory reform. Private Healthcare Australia recently estimated these reforms could release around $2.6 billion by the year 2020. We think that's certainly something worth pursuing. Prosthesis is also a clear example of technology moving so fast that regulation just can't seem to keep up with it. Customised 3D printed prostheses are increasing, and the regulatory framework doesn't know how to deal with this new technology. How do we ensure quality and safety of these devices, which are produced on a one-off basis, and how should the regulatory framework deal with these devices? And in fact, should it be the regulatory framework that does, or should we work together to see how we manage this increasingly fast new technology? So in terms of collaboration, as I said earlier, we have a shared challenge of ensuring the long-term sustainability of health insurance. And as such, we think that the focus of collaboration should be again around releasing savings that exist in the system today. So this means looking at waste and inefficiency throughout the system, high-cost new technology that isn't adding anything except cost. It hasn't delivering a benefit, and it isn't delivering better outcomes than the existing technology. Evidence-based treatments. So there are a lot of things done to people in hospitals today that perhaps have little or no evidence base, and I know that George Savides at CEDA recently talked about a journal in the Medical Journal of Australia about a study that found that around 156 items on our current MBS have potentially no medical efficacy, yet they continue to be paid for by Medicare and by health insurance. So should these be allowed to continue? We're not just talking about allocative efficiency here, we're talking about the right thing to do for patients. It's a big thing to go to hospital. So we believe that if we can agree together, health insurers and private hospitals, that the objective we both want is that health insurance remains affordable for all and work together to deliver it, then the discussions and negotiations between us would be very different. So at the moment, we feel we have no option but to focus on unit price. That's the only thing we can talk about. What we would rather be talking about is what else can we work on together to focus on delivering savings to ensure long-term sustainability. This approach would mean instead of having a war about profits and pricing, we would have a mature discussion that would benefit both parties and ultimately, and most importantly, patients. At Bupa, we've been very active already and forged collaborative and productive relationships with hospitals, and we believe that this work is moving us away from activity towards a focus on outcomes and quality. Bupa now has in place never events reporting with almost all hospital groups, and some hospitals have agreed to forego payment for these events. Seems to me a no-brainer, but right up until recently we were being asked to pay for things that were done to our members that just should never happen. A second key initiative is with HealthScope. It's our Pay for Quality initiative, and it shifts the focus from cost to value for money and provides a funding platform that allows Bupa to reward HealthScope for providing better healthcare outcomes in areas of clinical quality and safety. But it's not all down to insurers and private hospitals, of course. We need other players in the system to get involved as well, especially the doctors. Again, we have sought to forge relationships in this area. It's difficult as it can be from time, with a unique relationship that we have with Genesis Healthcare. We believe it's the only contracted arrangement with a corporate group, Kraft Group, which provides guarantee of no gap for our members. Now that's a great thing for our members, but importantly the arrangement also includes a commitment to public reporting of quality and performance measurement information, with the ultimate aim of benchmarking the data against guidelines and targets and improving quality for customers. However, there's much more to be done in this space, and Bupa believes that if private hospitals and private health insurers work together closely, we could show the other players in the health sector, including the medical profession, the value of this approach. We could bring them into the fold. And there's just one more thing I wanted to leave you with. We also think it's time for all funders, private, state and federal government and providers to come together and agree on shared goals for the health system as a whole and commit to working together to achieve them. There is a limited pot of money, and spending all our time and energy looking for ways to cost shift achieves nothing, and worst of all, delivers poor outcomes for patients. It's time to stop saying that we want a system that's patient-centric and start acting like we actually do. Yes, we have a complicated system. Sitting around lamenting the problems and waiting for big reform to happen quickly is not productive. Funders and providers need to get together and find ways to deliver the best outcome for patients despite the system. So while there are definitely areas of regulatory reform that will help affordability issues we collectively face, we believe the real solutions lie in collaboration and co-creation, and we look forward to moving along that journey together with you. Thank you.
So let me step through what I see as some opportunities between private hospitals and health funds, and I might address some of the issues that Ayela's just raised on the way through. Firstly, quality. Well, comments I'm going to make are not me as APHA president, as me as a private hospital operator for many years. We've talked a lot for many years about quality, and I must admit I start getting a little bit concerned that a lot of the conversations I hear is about quality as a way to reduce payments, not improve them or to refine them. Now, I'm pleased to hear that there is some change to that, but I can see an opportunity to continue my commentary earlier about what we're doing at Hervey Bay. Whether or not that proves to be correct, and I believe it will, I do believe that the opportunity exists for funders, being it governments or insurers, to have a differentiation of payments based on quality outcomes. The question is, how do you define those quality outcomes? And that's where I think the work with the Commission becomes quite critical, to have a third party that can actually work with all of the industry to identify what those clinical outcome standards should be. So cooperatively working to develop quality reporting I think is quite critical, and then looking at ways to financially incentivise those who are producing that good outcome. And to talk about prostheses is a challenging issue in its own right. We could stand here for ages talking about prostheses and the challenges that brings. The reality is technology is running ahead of us. And the reality is a number of those technological changes are significantly improving clinical outcomes. The challenge for hospital operators and for funders is to identify what they are and when they should be implemented. Clearly hospitals will want to do it more quickly, funders won't. There really hasn't been a very structured process for reviewing how that occurs. And pilots using true health economic modelling, I think, need to be undertaken in a structured way between operators and funders. Ayela talked about doctors and hospitals working together for value for money. Look, hospitals clearly work closely with doctors to assist in managing their patients in our hospitals for good clinical outcomes. We don't get involved as to whether that care is appropriate. That's actually a clinical decision. The funders, being governments and insurers, need to work with the medical profession if they're concerned that certain care is inappropriate. We will work with the doctors to ensure that length of stay is minimised. That's in our interests under case-based payments anyway, with appropriate clinical outcomes. But for us to start getting involved as to whether certain procedures are right or wrong, you know, you've got to start to work out how you define the definition of appropriate care, and that I think will be an interesting conversation with the medical community. And I accept that it's an important one to have, but that needs to be, and we will assist in bringing a number of those high-quality medical professionals to the table, but I think that's a conversation piece with the medical profession. Opportunities operationally. Well, we can work better on the frequent flyers, on the chronic disease management across the country. And there are a number of pilots that have occurred and some continue. And it is in the individual's interest, the consumer, to try and reduce the time that they spend in hospitals, which is always going to be a challenge for people having to come into hospital. So ways to better manage these frequent flyers is pretty fundamental, and health funds and hospitals have been playing in that space, and I think we need to play in it more often. There are contractual terms which differ significantly between funders with all hospitals. And I give an example of ICU classifications. Different funders will pay for the same procedure in a different way and will classify ICU patients in a different way. I mean, at the end of the day, an ICU patient's an ICU patient, and what they're being treated for requires an intensive care setting. And with the intensivist, you can actually identify quite clearly what the classification requirements would be. I fail to see why health funds differentiate on that definition. Auditing rules vary enormously between funds. It is currently causing the industry an enormous amount of heartache, and they vary enormously between funds. And again, different funds will take very different approaches, which causes a significant challenge to maintain strong relationships with the funders when those rules are so significantly different. And the same comes for billing. The standardisation of definitions and documentation on the billing rules, we all know, is enormously varied and causes a significant amount of additional work for hospital operators, which could quite easily be streamlined if there's a joint approach by the funds with the hospitals to get that standardisation. There are opportunities in joint lobbying. Clearly, I'm a fan and a zealot for digital health. I think that is going to be important into the future. And for your interest, as I didn't raise it earlier, I am now coordinating a senior group across the country of predominantly public hospital CEOs of major teaching hospitals and some of the senior bureaucrats in both federal and state to look at ways in which we can start to coordinate a lobby arrangement with the governments to recognise that supporting the implementation of electronic health financially into the health sector will be in their long-term benefit. And certainly from the health insurer's perspective, I think the same is going to apply. I think there are opportunities for us to work together to actually improve outcomes through the use of digital health. And I pick up on Ayela's point about integrated care funding options. In meetings that Michael Rolfe and I have had with the new Minister and the new Department Head of recent times, there is a renewed interest in looking at ways and models for a more integrated way to fund the integrated care. You'll hear many a conference theme around integrated care, and one of its biggest challenges is how you can integrate the funding. Well, you can't get more of a split in the way the funding is organised for healthcare than you can in this country. So ways to actually proactively work between federal, state, public and private, home and community as well as hospital funding, I think is quite a paramount piece, and will, I'm hoping, be seen as important by the current government and bureaucracy to look at future long-term benefits. And the barriers that I can see to having this closer cooperation is that there is a lack of trust. It's a lack of trust on both sides, and each side will give a different reason as to why there is a lack of trust, but the reality is we've got to get over that and move forward positively. I've mentioned before using quality as a proxy for reducing payments is something that I think needs to go out, and a more constructive commentary about the true definition of quality indicators and what you can define as better quality, and I know the Commission's working on that as we speak, and we are certainly being significant contributors to that. Lack of agreement between the funds and between hospitals is pretty fundamental. There is enormous difference. There's enormous difference between what funds approach the hospitals about, and there's enormous difference between how the hospitals approach back to the funds. And whilst you could argue that's the competitive nature of the business, the reality is that what happens is the private hospitals end up spending a significant amount of administrative time overcoming the differences between what funds require in terms of their reporting and the way in which they receive payment. So basically it all comes back to contracting and commercial issues, and I would be delighted if we could take a much more proactive approach to this. Thank you very much.
Good afternoon, everybody. Please bear with me, partly because I'm a ring-in for this session, but also because I'm just getting over a very bad cold, and this morning I had no voice. So if you can't hear me, that's why I've come up to this microphone rather than that one. So I'll do my best for you. But having said that, and Andrew introduced me as being a fan of The Sound of Music, but I actually think that the most appropriate song I could think of this gathering is actually not from The Sound of Music, but from the musical Oklahoma. You might remember it. It's towards the end of the musical or the end of the film, and there's been a bit of a range war going on right through the story. And in the end, they all get together and dance around and sing. The farmer and the cowman must be friends. But just following on from those two presentations. What strikes me about this space, about private health space generally, is not micro-managing the issues, but it's macro-managing. And one of the problems, I think, in the sector as a whole, which I'd like you to think about, is that the farmer and the cowman are not friends. They have a common interest in making the private health value proposition work, in making private health an attractive choice to consumers. And given that we're now nudging 50% to hospital coverage in terms of private health insurance, that's basically more than half the population who are covered in some way or other. Are we basically asking the question, what is best from their point of view as opposed to what is the best from our point of view? John Howard, who's somebody you may have heard of, had a very wise saying when he was Prime Minister, and that is that the things that unite us are greater than the things that divide us. That we all have a common commitment to the cause of private health, yet the one thing that strikes me about this sector is how little the parties, be it your sector, the private hospitals, be it insurers, be it doctors and other providers, and I love the AMA dearly, as if you've been following the GP co-payment debate, and Brian Ayela, if you're here, cheerio. Got something to say about you later, mate, but beyond that, the lack of cooperation, the lack of working towards that common cause in terms of reform that benefits everyone in the sector and certainly benefits our consumers is lacking. And it struck me when I was working in politics with both Michael Wooldridge in the early days and Tony Abbott later in the piece, and certainly in my time since, that issue after issue, it's seen as a let's take going back to 2008 when the Medicare levy surcharge reforms were introduced by the Rudd government. The then Australian Health Insurance Association went bananas. The Private Hospitals Association wanted to help, but yet they did not work together very well at all. Michael might say not at all. I don't know. He might say it was brilliant. But the problem is that it allowed the opponents of the private health value proposition, in that case the then government, to divide and conquer, and they did. They did. And that is a problem that we all have. So when you do have your in-house friendly disputes about, well, dare I say, contracting, or what should be covered, about the cost of prostheses, about, if you like, medical moral hazard and how that affects what you do as providers of hospital services as well as payers of them. Those conversations are not having, because I think there's two, and Richard's slide, is it still there? No. The slide about lack of trust, I think, goes right across the sector. And it's so frustrating watching it, trying to make policy when you're a policymaker in regards to it. And the bureaucracy don't understand how you operate. Let's get that right as well. They don't understand what it is like to run a business. They can tell you about policy, they can tell you about budgeting in a federal budgetary type of sense, but they can't talk about, they look at your balance sheet and they look at your profit and loss line and say, oh, look, they're doing all right out of this, so we can leave things as they are. Or no, they're not doing all right, things need to change. So those are the types of perceptions of the people you're dealing with, let alone the media who report to the public and the public themselves, those consumers who you want to actually bring along with you, to develop long-term relationships with, to have them grow old with you, so to speak. That needs to happen more. And it's important, I think, to deal with the creaky ship of private health and private health insurance. Really, since the cover reforms of 2006-7, there hasn't really been anything done. There have been piecemeal changes for budgetary and ideological reasons from the previous government, and to be honest, I think partly as a result of the GP co-payment debate that I was involved in, I think they're going to be reform shy at least for this term and probably the next one in health. I think one regret about the co-payment debate is not about talking about price signals, it's actually that it's swamped the reform conversation and it has swamped the political urge to actually do something about it. So I think it's important that we collectively work together to actually restart that conversation. If ministers won't do it, basically your enemies are, your enemies in an ideological and a political sense are going to define the turf for you. And is that something that any of us in this room want? Can I actually do a show of hands? Are there doctors in the room today? Oh, Michael, of course you're a doctor. But doctors representing as doctors as opposed to private hospitals? Are there any people from government here? Oh, you're looking very lonely. Besides Ayela, are there any private health insurers here? Oh, hiding up the back for a quick getaway, that's all right. Yeah, look, I think it's important that all of you get together. I mean, you not just get together for drinks afterwards and hopefully a conference dinner. I'm told there's a very good comedian, Michael, but just in general, I mean, interact with each other, try and get an insight into what each other thinks as opposed to confronting each other across negotiating tables. I mean, that's really part of what you need to do. And I think collectively, the three sectors, and I think consumers as well, consumers especially, I should say, need to actually get together and get a consensus about what macro reform needs to be done to private health policy, to private health regulation, and to private health legislation to make things happen. Now, I have a few suggestions about macro reform here, and I could run down them now, but I'm sure I'll get a question from the floor in a minute. But I think we have to go above the level that Ayela and Richard were talking about and look at the bigger picture of private health and how we make that better. And as a frustrated policymaker, hollow man, consultant, GP co-payment guy, I'd love to see you come and join me in the trenches. So let's discuss it now. Thank you.
All right, thanks very much, Terry, particularly, as you said, hasn't been well and filling in at the last minute. We do appreciate that. So, ladies and gentlemen, with that, our three panellists are happy to take... I don't know if Ayela's happy to take questions, but they're all agreeable to take questions. We've got the microphones floating around in the middle. If anyone has got a question, if you can make your way to the microphone as that rush is taking place. Ayela, I might start with you. I've got a question for you. Just given what you were saying at the start, can you summarise then what areas insurers like Bupa are most keen to work collaboratively with hospitals on?
Okay, so I think I mentioned quite a few of them throughout the speech, but I'd probably say there are 6 areas that we have been, and we've been pretty transparent about this when we have spoken to providers, both doctors and hospitals. So sustainable affordability being the key thing throughout what I was talking about. Care based on best evidence, again, what I mentioned. Shared decision-making with patients, so bringing the patients right into the centre, really what Terry was saying. We need to start looking at it from their perspective. Outcome measurement and reporting, agree that I totally agree with what you said, that we should agree as an industry on a set of measures and how they should be dealt with.
So you look at the agreement we've got.
Yeah, already. Yeah, managing patients' health risk. And I think one of the things I didn't mention in there was some discharge, so best practice, consistent discharge planning would be really something we would really welcome. And improving the members' experience, which is just, at the heart of it, they're coming into your hospitals and it's an experience for them, and we'd like to make that as wonderful as possible for them, given the circumstances. And I guess the other thing that I would mention too is, we have a largely fee-for-service funding model pretty much across the system. And it's been 15 years, I think, since episodic payments were first brought in by health insurers. So I guess I'd say, we're waiting, we're interested, we want to hear, do you have a new funding model? Would you like to chat to us about it? We're very keen to look at what we can do to move away from a fee-for-service activity-based approach.
Okay. Thanks, Ayela. I might fire another question. Terry, from the government or from the Health Minister's point of view, what would you say would constitute nirvana in terms of private health sector collaboration, and do you think that that's actually achievable?
Nirvana. They broke up, didn't they?
They did.
Lead singers, so it's not available anymore. I think, look, as I said just then, I think the Health Minister at the moment is looking for a quiet life. She's got enough on her plate in relation to interesting calls that were made by the government over the last 12 months that she's cleaning up. I don't see any appetite in the government at the moment for any significant reform beyond doing that tidying up. And as I've said elsewhere, I think the Australian Medical Association, because of the political capitulations of both government and opposition, have actually captured the job. So if you're talking about what makes the Health Minister comfortable, ask my good friend Brian Ayela. Because effectively the AMA at the moment is calling the shots, because they're saying we decide who comes to Medicare and the circumstances in which they come. But I think there is a great opportunity here, it's probably a better way to answer your question, to engage in some serious structural reform of private health that can be led from the centre, which is what government is there to do, and is going above and beyond simply who pays for what. And that's a conversation that we really do need to have.
Okay, now Terry, you've mentioned the AMA. We have a question here on Twitter directed at you. Terry, if private hospitals and health funds are the farmer and the cowman, what does that make the AMA?
The bull. I reckon Judd, as in poor Judd is dead. But Richard's right. I think the bull, and also perhaps occasionally what comes out of it. I didn't say that. Look, as I said,
Twitter is going wild right now. We are trending.
But I actually think in this conversation, the AMA is the rustler, coming to steal the cattle from the cowman and actually burn the crops of the farmer. Now you have to work out who's the farmer and who's the cowman from that. But because effectively they're saying that doctors call the shots. They actually define what is right and what is not in healthcare, in health policy, in private health as a sector. And I'll say a bit more about specialist charging in the session I'm actually booked to do. But it's important, I think, that they realise that they need you, the private hospital sector, you, the health insurance sector, just as much as you need them. And at the moment, I think there is an imbalance in the relationship, and that the AMA is actually exploiting that. And again, it comes down to what I said before. It's important to get a consensus between the parties about what the private health value proposition is, what private health is all about, and where it's going to go. And I think the AMA at the moment, because of the way that the GP co-payment debate has changed the dynamic, is actually in the box seat and needs to actually be taken down a peg, frankly.
Okay, thanks, Terry. I just want to check before we go to more questions whether we've got any questions in the room. Oh, we do? Thank you, over here.
Cindy Shea, HCF. I'm not sure who to direct this question to, but I actually wonder at a macro level that what we're actually seeing disappear is the idea of complementary, as in private and public being complementary services, and now having split services. And the example I would give is I think the federal government still believes it's complementary, but we see state governments I think saying it's a split service, in Victoria the example would be ambulance transfers, where suddenly if you're in a private hospital you can't be transferred without you paying it. And New South Wales, we've got very similar examples. So I just wonder at a macro level, is that really happening around us and we're not paying sufficient attention to what that might mean for us?
I think I've been dobbed in. I think that it is increasingly blurred between complementary and supplementary. You would think that in the public hospital sector at state level it should be supplementary, but when you have states and hospital authorities actually actively touting for private patient business, clearly they've decided it's more than complementary, it's actually essential. So nobody's asked me what my list of reforms would be, but certainly on them I did actually say that we should be removing second tier default benefit from public hospitals. I think that allows them to compete unfairly for private patients. I believe that a very first op-ed I did after I left politics was on the subject in 2008. I haven't changed my view. But I think it would also encourage states to partner more with the private hospital sector so that you'd co-locate more than is happening now to get the private patient dollar into your campus. I don't think that's really been exploited enough, as opposed to the simple, oh, we'll take second tier and throw in all these bells and whistles for you. I think that's actually undermined the private health proposition on the one hand, but it's also propped up less than optimal health system and public hospital governance on the other.
I agree with Terry that I think the unfortunate decisions made over the last 12 months by the federal government in the health arena will lead to some policy-free zones in terms of major improvements or changes and refinements of health policy, which is a real shame because, you know, you asked earlier about nirvana. If you could be provocative, you'd say, I'd go back to the discussion we were having earlier in the day about digital health. Population health models are currently being piloted in various parts of the world, and it's very interesting to look at the outcomes of those because they're using predictive analytics, which are getting more and more refined, and overlaying the data that comes out of people's health experience, and then overlaying their own demographics and genetic history, and coming up with the future potential coverage or future potential issues people are going to have to deal with in their health. That ultimately leads to something which the current government won't want to touch, which is under a different word, capitation, which is going to have to start looking at dollars paid per individual life based on a much more comprehensive data platforms, which are starting now to become available. And if we're serious in the longer term, that's the way I think we're going to have to manage it, because I have to agree, the ongoing fee-for-service model isn't going to be sustainable as the population ages. It's pretty simple. People are getting older and they're going to use more health services and they're costing more money, so that has to be limited somehow. So that's one option.
Okay, thanks, Richard. I'll throw another question at any of you or all of you. Recently, the APHA and Private Healthcare Australia were involved in joint lobbying in relation to means testing of the health insurance rebate. What other issues should we be jointly lobbying on? Richard, you mentioned e-health, but are there any others?
I guess the overall reform, exactly what Terry's been talking about. What do we want the future of private health to be in this country? What are we moving towards? Are we staying sitting alongside Medicare? Are we evolving into something slightly different? And how do we make it work for all Australians, ensuring the system as a whole is sustainable?
Doesn't that actually mean that you have to get yourselves in the room and basically throw away the key and actually come out with something like a vision manifesto?
Yeah.
Because that's what's been lacking from the sector as a whole. And I don't want to talk too much, but it's good that...
I'll talk to you.
I'm a hollow man. I don't talk at all. It's good that APHA and I still think of them as the Australian Health Insurance Association because I think if with respect to them, calling themselves Private Health Australia is arrogantly assuming that health insurance is the be-all and end-all of private health. So I dispute that. I think it's important you work together. I think it's important. All right, I've had a little dig at the AMA. I grant you that, but I think it's important that they and craft groups actually and consumers work together. I think that there needs to be some sort of brokered forum. That may be what government can usefully do for the rest of this term, is to actually try and bring those parties together and get some consensus going, because when you focus on your own agenda, even with the best intentions about the higher purpose, you're not going to get anywhere. And that's the problem.
And I think probably I'll just add one more short-term one that we probably need to be really keeping an eye on is downgrading and the impact of the changes that have been happening. What can we do together? What ideas can we lobby for to help drive greater participation potentially, and also helping to stop the downgrading, because the more people are downgrading, the less likely they are going to be able to have a product that covers them for services in the private hospital sector as well.
I think the notion of health insurers taking a broader participation in the provision of health care for an individual has a lot of logic to it, which obviously requires some regulatory change, but I think has a lot of merit, and I will personally be supporting it.
Thanks, Richard. Do we have any more questions? If we don't, in that case, I'll just encourage those of you who are here from the various sectors to continue that conversation over the course of the next couple of days. Please join with me and thank Terry, thank Richard, and thanks Ayela. Thank you very much.